Assalamu alaikum wa rahmatullah. Good morning, everybody. Mansoura Manchester program. My name is Dr. Muhammad Abdel Khalek, lecturer of surgical oncology in Oncology Center, Mansoura University. Today's lecture is about the acute presentations of colorectal cancer. We are going to focus on the obstruction and perforation as complications. Okay. As we all know, there is some types of cancers that has screening programs. Of course, we know breast cancer, cervical cancer in women, and colorectal cancers. But despite such programs, in colorectal cancer especially, up to 30% of the patients with colorectal cancer still can present with symptoms requiring acute or emergent surgical intervention. Such presentations include, as we mentioned in the first slide, obstruction, perforation, and to lesser extent hemorrhage, as we are going to discuss later. Of course, there is a great difference between two types of patients. One who was managed electively, and the other who was managed as emergency. Outcomes are, of course, different between these two types of patients. For two major reasons. One of them is concerned with the patient himself, because the patient who came in emergency, mostly he is not well prepared, mostly he is not hemodynamically stable. The other reason is the tumor itself, the tumor biology. Cancers which was resected in emergency are typically of more advanced T stage, which means it's locally advanced. Also, it comes with higher histologic grade and more likely to have lymphovascular invasion, which means it's more aggressive. Today's lecture is gonna go around some points. We are gonna summarize it in this slide. As regard obstruction, we have either colonic or large bowel obstruction and rectal obstruction. Regarding colon obstruction, there is two types: the proximal obstruction or distal obstruction, and we are when we say proximal and distal, we mean in relation to splenic flexure. So in proximal colon obstruction, it will be treated just with resection and anastomosis. This is our point to be fulfilled. In distal obstruction, it has more treatment options, as we are gonna discuss also later. In obstructing rectal cancer is treated with proximal diversion to allow for neoadjuvant therapy. Also, this is a critical point. We are going to discuss it in its position. That was for obstruction. For perforation, it depends on the degree of peritoneal contamination. The last point will be about the hemorrhage. Not all types of hemorrhage, of course. We are talking about the emergency, so massive hemorrhage, which is actually uncommon in colorectal cancer, and we are going to discuss how to treat it. Okay, so our first point to discuss is the large bowel or colon obstruction. So, of the three major points of the emergency in colorectal cancers, obstruction is the most common symptom of it, with an incidence which can reach to 30%. Also, it is the most common indication for surgical interference. It can reach up to 77% of emergency. Of course, not all colonic obstruction which is coming to an emergency department or emergency hospital, it's because of colon cancer. But if you are gonna deal with an adult, it should be the first point of suspicion. So, surgery for such obstructions in an adult presenting acutely should be performed in an oncologic fashion. Oncologic fashion means they are gonna operate in the principle of you are doing resection for colon cancer. As we said, because most of these cases will be eventually recognized as colon cancer. Of course, when you do the pathology afterwards, because you didn't have the time to have a preoperative biopsy. Okay, for diagnosis of colonic obstruction, computed tomography or CT is the imaging modality of choice for patients presenting with such symptoms. It's readily available in emergency departments, as طوارئ hospital here in Mansoura. It is very beneficial and can localize an obstructing lesion with a sensitivity of about 96% and specificity of 93 to 95%. When we use CT, we use it in the modality of triphasic CT. Triphasic CT means you do an oral, rectal, and intravenous contrast. It will give you more beneficial data. Another important advantage of the CT that it can also offer accurate staging about both loco-regional and distant spread of the cancer. Another good and beneficial modality, radiological modality, is using hydrosoluble contrast enema, such as gastrografin enema. It's also valuable and has a very high sensitivity and specificity. Sensitivity of about 80%, specificity of about 100%, especially when you have a stool-filled colon, because in such conditions, CT may not be able to identify small lesions that could be apparent on using contrast enema. For elective patients, of course, it's a must to use a colonoscope to see the tumor from inside, to take a biopsy from it, and also to assess the rest of the colon. But in such emergent cases, it's not appropriate, and actually we don't prefer it because in some times it can cause more complications. It can lead to perforation and later on, of course, toxemia or septicemia. The one good thing that we can use colonoscope in some selected patients to relieve obstruction with placement of what's called SEMS or endoluminal stent. We are gonna discuss it in a few slides later. In this photo we can see a CT section in a patient suffering from colonic obstruction, sigmoid obstruction. You can see here there is a dilated loop with the white arrow inside. This is the cecum, so it is proximal to the site of obstruction, so we can see it is hugely dilated. And what is pathognomonic here, or very important to see, the air fluid level. This is accurate to diagnose obstruction, as we mentioned. In this photo, we are using the other modality we discussed, the contrast enema, gastrografin enema. In this photo, you can see the red arrow pointing at an area between the rectum below and the sigmoid above. You can see an annular structure, which is the annular carcinoma at exactly the rectosigmoid junction. As we said, in colon obstruction, we divide it into either proximal or distal in relation to the splenic flexure, proximal to splenic flexure or distal to splenic flexure, with the site of disease having a significant impact on treatment options. Left colon is more prone to be obstructed because, especially in the sigmoid or rectosigmoid junction, as we saw in the previous photo. Reason for this include that more of the tumors in such locations are morphologically more annular, as we saw also in the previous picture. Also because of this, in the left colon or descending colon, it's more narrow than the right side or the ascending colon, and also because that stool in this part of the colon is more thick and more hard because most of the water inside is absorbed. On the other hand, right colon or ascending colon has wider lumen. That means that obstructions are less common and happens more late. But it also means that if you discovered it late, it means that the tumor is very large. Okay. In proximal obstructions, because of the larger diameter of the cecum and ascending colon, as we mentioned before, right-sided obstructions are less common and thought to represent bulky tumors of more advanced stage as well. Some studies found that the disease-free survival in such proximal obstructions are lower, of course, if we compared it with the distal type. It was found independent of perioperative complications or conditions or even presence of metastasis in the lymph nodes. The good thing about proximal obstructions that it has more simple decision tree than distal obstructions. It's more easy, less technically demanding because the part you are gonna resect is usually more mobile than the left colon. So you can resect it and do ileocolic anastomosis in the end. The problem of such operations and the nightmare of every surgeon is the leakage after anastomosis. But it was found in many studies in after right hemicolectomy or even extended right hemicolectomy. In the emergency operations, it was the leakage rate was estimated to be from 2.5 to 4.5%, which is slightly higher than in elective conditions, which range from 1 to 2%. So it's not that dangerous. It should be. Of course, the tumor location will affect the type of surgery. So, if the obstructing tumor was in the cecum or the proximal part of the ascending colon, we are gonna do what's called, I'm sure you know, the standard or comprehensive right hemicolectomy, in which you remove the distal part of ileum, cecum, appendix, and ascending colon, of course with good safety margin above the tumor, and then you do anastomosis between the ileum and the transverse colon. And if the tumor was in the transverse colon itself, we are gonna do what's called extended right hemicolectomy, which is the same operation we mentioned, but you remove the whole transverse colon with you, and then you do ileocolic anastomosis with the descending colon. Why we do extended hemicolectomy? Because the area at the splenic flexure, it's called the watershed area, which means that the blood supply in this area is weak. It depends on the terminal branches of the named vessels, the middle colic and left colic. The terminal branches of left colic, the terminal branches of the middle colic supply this area. So it will be risky to do anastomosis with splenic flexure because you need good vascularization to prevent leakage. For distal obstructions, as we said, the diameter of the bowel is more narrow, the stool is more thick or hard, so the descending colon and sigmoid colon are common sites for obstruction. But there is difference that in the treatment options. If the obstruction is distal, the surgeons have more options to use to treat. Our first option here is called doing loop colostomy. Remember when we said in the beginning that we have to manage this patient as with a curative intent on oncological basis? We could do it in proximal obstructions because we had the chance or the opportunity to remove the affected part and then do anastomosis. But in distal obstructions, it's more difficult. So we have to do something in the beginning to make things easy later. First of them is the loop colostomy. What is the idea? The idea is to provide a definitive oncological resection in staged approach, usually 3 stages. First stage is to do the loop colostomy, which means we do a stoma proximal to the obstructed part, so the distension is relieved and the general condition of the patient is better. Then in the second stage we can go for the definitive surgery. So in the that was the first stage. The second stage, the tumor will be resected and the stoma could be reversed in this also, so it will be 2 stages, or we can divide it into 3 stages. First stage is the loop colostomy, second stage is resection of the tumor, and then third stage is to reverse the colostomy and return it to normal anastomosis again. The idea or the benefit of this staged operations or approach is to minimize the operative time and surgical trauma during the acute presentation when the physiologic conditions and the tissue integrity is not that optimal. Second option is called Hartmann operation or Hartmann resection. which involves the resection of the primary lesion with creation of an end colostomy and closing the distal part, either colon or rectum, which means I'm gonna remove the tumor, the part of the colon including the tumor, and close the distal part permanently, and come with a stoma which is proximal to the previously obstructed colon, and put it on the skin. The disadvantage of it that it will be for life. Statistically, Hartmann resection is currently the most common operation performed for distal colon carcinomas, especially in the emergency, and also especially by general surgeons. For us oncological surgeons, we don't like it that much. We are always thinking to have less complications and not to go for permanent stoma. Another option we have is like what we did in the proximal obstructions in the right colon, which is the single stage primary resection anastomosis. Well, actually we cannot do it in all patients because it is considered too high of a risk in the emergency setting. We can go for it, but after wise selection of our patients. There is specific factors. If you found it in your patient, I recommend not to go for single stage resection anastomosis. Such factors which is associated with poor outcomes. If you found that your patient is more than 70, if the ASA score grading from 3 to 4, if there is preoperative renal failure, if your operation will be within 24 hours of the first presentation, and also if the cancer stage was advanced or high. If any of these factors were found, I advise you to go for one of the previous two options, either Hartmann or lobe colostomy first. Another option we have is the total abdominal colectomy, in which we remove the whole colon. It is another option in some cases. It could be beneficial because it removes the whole distended parts and the potentially ischemic proximal colon. So we go back to the healthy terminal ileum for primary anastomosis. It's ideal in some cases, of course, especially if we have more than one lesion in more than one part, synchronous tumor I mean. So if you have a lesion by CT in the left colon, in the descending, in the sigmoid, and transverse and ascending, so in such condition you remove the whole colon. We don't recommend to do double anastomosis. I mean, if you have two tumors, one in the descending and one in the ascending, okay, theoretically you can go for resection anastomosis in the left and resection anastomosis in the right, but then you have two anastomosis in a not that good patient, because of course you met him in the emergency, so you are risking with the patient for a very high rate of leakage, so we do not recommend this. Last option we can use here, it's called the SIMS. It stands for self-expanding metal stents. Of course it's not an operative modality to face such obstructions, but we can use it in special cases, especially the patient is not fit for surgery, or as palliative measure if the patient is with distant metastasis in the liver or lung, so there is no curative surgery, so it's not that wise. Or if the tumor itself is not resectable, if it's locally advanced and invading the surrounding muscles, the urinary bladder, whatever. So in such condition we can use this metal stents. In some cases, but it's not that common, it can be used as bridge therapy, bridge to surgery, with the goal of enhancing the condition and to enable elective resection later. In this slide we can see in the first photo to the left, you can see the stent when it's expanded outside the body. The second photo on the right, you can see in photo number A, you can see the by endoscope we can see the tumor in photo number B, after placement of this self-expanding stent, so it allows for passage of the stool and to improve the condition a little bit. Here we have a coronal view of a CT image of the body showing there is a stent in the descending colon. You can see it inside the white circle. It's also a good photo because you can, if you had a look at the liver, you will find that there is many metastases, and also there is some metastasis in the peritoneum. What I mean that it was not a candidate for curative surgery, so the stent with a good was a good option for him. So we spoke about obstruction when it's in the colon. Now, what if the obstruction is due to rectal cancer? The idea is the same, but there is some differences. First, rectal cancer to be obstructing is not that common because the patient usually seeks medical advice before. Why? Because when there is tumor emerging in the rectum, it will give us some alarming signs such as bleeding. So when the patient finds that every day there is bright red color in his stool or in between, he will be so worried and will seek medical advice, and it could be discovered before it causes obstruction. If rectal cancer presenting with acute obstructive symptoms was found, it's usually, of course, of locally advanced stage. The difference between rectum and colon is that we need to go for what's called neoadjuvant concurrent chemoradiotherapy. According to guidelines, if the tumor is locally advanced in the rectum, I mean, to reach the optimum surgery, you have to do chemoradiotherapy first before surgery. Concurrent chemo and radiotherapy before surgery. This will enhance the results oncologically, I mean. So we have to do some things before to allow for such neoadjuvant therapy. So we are gonna use the same as we mentioned before. First is the either loop ileostomy or colostomy. So in patients with obstructing middle or low rectal cancers without finding of metastatic spread, simple diversion will provide the opportunity to complete the staging and to give the neoadjuvant chemoradiation with a staged oncologic resection for curative intent. Loop colostomy will allow for a decompression as well as to assess the proximal colon to find if there is another lesions or not. But the problem of loop colostomy that it will affect the future anastomosis again. So for us, we mostly prefer to do a loop ileostomy. So a loop ileostomy will work better for these patients because I'm not affecting the colon, so in the future surgery I can do resection and anastomosis more easily. The second option is the Hartmann resection. In the case obstructing carcinomas in the upper rectum, Hartmann procedure may be chosen, providing a definitive resection without added risk of anastomosis. This option can be appropriate for older patients, as we mentioned before, with comorbidities, even in the absence of acute obstruction. But patients should be counseled before, and they should be aware that colostomy reversal is extremely not common. Last option we have is the SIMS, the self-expandable metal stents. As we described before, for distal colon cancer, its use for obstructing rectal cancer is most appropriate if patients with widely metastatic disease who will benefit mostly from systemic chemotherapy, or who are too physiologically stressed to tolerate operations such as low anterior resection or even abdominoperineal resection with permanent stoma. But there is risk of tumor perforation during placement of such stents. So the placement of rectal stents carries significant risk of either perforation or even distal migration and severe tenesmus later on. Therefore, we prefer to do SIMS to be limited to the lesions in the upper rectum. Second most common reason for urgent emergent surgery in colorectal cancer is the perforation. It has a high incidence, actually reaching up to 10 to 12%. It depends on the location because it has two types. It may progress to either free or contained perforation. Free if it's not localized, contained if it's localized by the omentum, for example, and doing or making an abscess. Perforation most commonly occur at the site of primary tumor, of course, because it's invading the wall of the colon until it causes perforation due to pressure necrosis, or it can precede this and happen proximally to the obstructing site because of the dilatation proximal to the obstructing part. So the wall is becoming more thin and can be perforated easily. Although perforation is not the most common presentation of acute presentation of colorectal cancer, but it is the most lethal complication of colorectal carcinoma. Some studies found that mortality associated with secondary peritonitis from such perforation is high. It can reach up to 30 to 50%. So we say that perforation could lead to one of two types, either free perforation or contained. First is the free perforation with spillage into the peritoneum, which will be diagnosed or suspected by the classic finding of generalized peritonitis, including the involuntary muscle guarding and rebound tenderness. Well, CT as an imaging modality will be very accurate in diagnosis such complication, with very high sensitivity up to 95% and specificity also up to 95 or even more percent. It will show there is free air or free fluid at the site of perforation, so it can be diagnosed. How to deal with it surgically? Of course, it's emergency. You have to explore. We will do open exploration, and we do a very good washing to the peritoneal lavage or wash out, with the trial of identification of the diseased or perforated site. As we said also that when we localize the perforation area, the resection of the perforated site should stick to the principles of the oncologic resection with the lymphadenectomy for accurate pathologic staging afterwards. If we are wishing to go for primary anastomosis, it can be considered in carefully selected patients. Patient with no bad criteria, as we mentioned before, the age and the general condition, as we mentioned previously. We can go for anastomosis, but never to do just primary anastomosis. You have to protect it with a proximal diverting ileostomy to give more chance for anastomosis and for healing of the anastomosis and to prevent leakage. The second type is the contained. The rule for percutaneous drainage of contained perforation from carcinoma differs from that of benign diseases. Percutaneous drainage, we mean it's not operative technique. You just go for radiological guided insertion of wide pore needle inside the abscess and do drainage. But it differs from benign to malignant. So in the presence of widely metastatic disease, treatment with antibiotic and percutaneous drainage will avoid the morbidity of an operation. it can be justified in such cases. But in other cases, drawn out infectious complication can forestall systemic chemotherapy. On the other hand, in absence of widely disseminated disease, percutaneous drainage of contained perforation or abscess may result in seeding tumor cells along the drainage tract, so it will increase the metastasis. So again, if malignancy is suspected, the patient condition is okay, there is no distant metastasis, we will recommend to go for exploration and managing with the cause. And perforation or abscess, which can be presented with just localized tenderness. Many cases of perforated colorectal cancers presenting as abscess are not diagnosed preoperatively and can be shown like diverticulitis or even appendicitis on CT imaging. The title of the lecture has only obstruction and perforation as emergency presentation of colorectal cancer, but and it's true, these two are the most common. But if you go for and read for in the literature, you will find there are three. So we have to put the bleeding with it. It's not that common, it's just one slide, but you have to know it's one of the acute presentations also. Gastrointestinal bleeding is very common with patients with colorectal cancer. They are like more than 50% will be suffering from it, but most of it's not emergency. Most of it is of low volume, it's self-limited, doesn't require any emergent surgical intervention. Only in the cases of acute massive bleeding of a colorectal cancer can be considered emergency, but luckily it's very rare actually. As any massive bleeding from any side, upper GIT, lower GIT, the initial management will be resuscitation. You will establish a large pore IV access, give fluids, crystalloid, try to correct the underlying coagulopathy, to adjust the INR or any other metabolic abnormality to prepare the patient for dealing with the actual cause of bleeding. If we succeeded to make the patient stable, we can go for endoscopy, which will identify the source, the bleeding source in like 75% of cases, and deal with it, although this technique may be limited in unprepared colon. In some cases we can go for embolization. Angioembolization, I mean you make embolization of the feeding vessel. It has success rate ranging from like 40 to 80%. However, it carries the risk of worsening the intestinal ischemia. This option may be more attractive in cases with metastasis to avoid laparotomy and associated delays in systemic chemotherapy. Eventually, surgery still the preferred option to deal with such problem, the bleeding colorectal cancer, I mean. And again, for the third time, when you localize the site of bleeding, resection should adhere to the oncologic principle with curative intent. That's it. I hope you could get benefit from this lecture. For me, it is the first time to make such a lecture online. Of course, we missed the actual interaction. If there is any questions, something like this, but it is the COVID-19 era, so stay home, stay safe. Okay, so whoever is watching this video, thank you. If there is any question I couldn't answer, of course, because we are not meeting, here is my email. Send me anything you wanna know and I'm gonna reply. Good luck. السلام عليكم.